Shoulder pain, ladies and gentlemen. I get a good number of patients consulting with me for shoulder injuries, be it associated with an injury in the gym, on the back of a trauma, on the back of a fall, or even having woken up with the symptoms, or in the absence of any mechanism at all. So what am I thinking? What's running through my mind? What are the possible diagnoses? And now you'll appreciate the shoulder complex is a very, very complex joint. The shoulder joint itself is not alone. Just reviewing the anatomy very basically and briefly, we've got the collarbone over here, and the collarbone on the distal end articulates with what we call the acromion. The acromion, as I describe it, is an extension like the kind of the cobra head of the shoulder blade when you look at it side on. So the shoulder blade, of course, sits at the back of the scapula, and the projection comes forward, articulates with the distal end of the clavicle, forming the acromioclavicular joint, the AC joint. The actual shoulder joint itself, the main part of the shoulder joint is here, what we call the glenohumeral joint. Why? Because they've got the humerus, the head of the humerus, articulating like so, articulating with the glenoid cavity, which again is a kind of a cup-shaped structure like so, deepened with a labrum, a kind of a ring, and that again is part of the scapula, the shoulder blade. So that's the true shoulder joint, the glenohumeral joint. But then over here we've got the AC joint, and then here we've got what we call the coracoid process, another structure, again part of the scapula. So, patient presenting to me with shoulder pain, the first thing I'm asking is where the pain is located, whether it's on the anterior, the frontal aspect, the lateral borders, the lateral the side, or the posterior aspect, if not the superior, and very, very rarely, occasionally inferior, i.e. in the armpit, or otherwise known as the axillary region. Causes of shoulder pain, there are numerous. So let's start with the musculoskeletal and the kind of things I might see. Number one on my list, probably the most common one that I see, is in fact not what most people would consider. Most people would think shoulder injury, trauma or no trauma, rotator cuff. And no, it's not what I see most of. In fact, what I see most of is a strain to the AC joint, the acromioclavicular joint. There is a capsule around this joint, and what I find is patients who are in the gym having done particular regime exercises, there's a good chance that they've actually strained the capsule, responds extremely well to treatment, and that's probably the most common thing I see in the clinical setting as an osteopath. Secondary to that in the shoulder associated injury is probably supraspinatus tendonitis. So the supraspinatus is one of the four muscles that make up the rotator cuff, known as the supraspinatus, the infraspinatus, the teres minor, and the subscapularis. These four muscles essentially provide stability for the shoulder joint. The shoulder joint is analogous to the hip joint, except it's nowhere near as deep. And so because it's much shallower, it requires a lot more muscular support, and the rotator cuff is what provides stability for the shoulder. The supraspinatus, it runs deep to the upper trapezius over here, and the tendon to the supraspinatus runs under this arch. So when you look side on, it forms what we call a bony arch, what we call the subacromial arch. So the acromial arch, and underneath that there's a gap between the head of the humerus and this bony arch over here when you're looking at side on, and through there exits the supraspinatus tendon to insert over on this region here, deep to the lateral deltoid. Again, occasions where people have done overhead activity, having slept on it, or having done a good workout, shoulder workout, and then gone and slept on it, will lead to supraspinatus tendonitis. With supraspinatus tendonitis, you can also, if there's trauma involved usually, or if it's chronic, you can actually get bursitis. So bursi are fluid-filled sac. They sit between the tendon and the bone, and the purpose is to actually reduce the friction between the tendon and the bone, and vice versa. So if you have got tightness of the actual muscle, that puts tension on the tendon, and that tendon then presses excessively against the bursa, irritating the bursa, leading to the inflammation, because the natural response for the body to inflammation is to irritation is inflammation. So hence bursitis in the given situation is what we call subacromial bursitis. So when we see supraspinatus tendonitis, on its own it responds well to manual therapy. If there's an element of bursitis, then it takes a little bit longer to respond, and on the rare occurrence it doesn't respond in completion. The other thing which we could have in the same region is calcification of the tendon, supraspinatus tendon. We see that a little bit more in the older population, but not necessarily always. So remember, 40 years onwards, and the tendons in the shoulder actually start to degenerate. They start to undergo better wear and tear, what we call tendinosis. That's with or without exercise. Of course, if you've been exercising during your youth, then of course there's an accelerated process there, and the wear and tear will be that little bit greater. Appreciate that, and then you look at calcification. Calcification is visible on X-ray or otherwise ultrasound. The consistency of this calcium deposition in the tendon is similar to that of toothpaste, and again we can extract it surgically and do away with. It could be my apology. There could be a spur, a bony spur in and around the region, again encroaching on the subacromial space, thus irritating the tendon. That again visible on X-ray or ultrasound. Better ultrasound in the given situation again, and you would require surgical excision for the same. You can then have on the frontal aspect going back, you can have the actual biceps tendon. So the biceps tendon runs superior, the long head of the biceps tendon inserts onto the AC joint, runs in the bicipital groove and held across here by the transverse ligament. If, for example, you've been doing excessive workout on the biceps or otherwise an activity that you might not otherwise normally do, you can again present with tendonitis over here. Now, in the vast majority of the population, that is actually an area that's relatively tender for most people. So when you're examining, strictly speaking, any examination on the shoulder should be done bilaterally on both sides. Comparing with the good shoulder, that's not problematic. But this one in particular, because it's normally tender anyway, it's worth checking against the other side to see if it's any more tender than is the other side. Okay, so we've done biceps, we've done that, we've done... Okay, what are the... So then there's the basic stuff, then there's a pec strain. Okay, make sure the pec tendon, again, the pecs go and insert onto the AC joint. You've got the basic muscular strain, so deltoid muscle strain. On the posterior aspect, again, you can have the actual muscles, the infraspinatus and as well, slightly lower on the shoulder blade. Around the back, between the shoulder blade, the spine of the shoulder blade, and the actual vertebrae, what we call the paraspinal region, you've got the rhomboids running there, you've got the lumbar erector spinae, you've got the cervical erector spinae, and so the cervical, you've got the semispinalis and the cervices. These muscles also could be strained, or otherwise you could have a trigger point in and around this region. So splenius capitis, splenius cervicis, sorry, the two muscles are thinking with the CES stroke the TES. So they again could be giving you, so prolonged use on a computer, prolonged periods of reading, prolonged periods of sitting stationary, driving, these issues, that concentration, that sitting still requires a muscular use, a prolonged muscular use. That's static may well lead to formation of trigger points, and that could also be a manifestation which can also actually give you a sensation down the arm, replicating a trapped nerve if it becomes inactive from a satellite. Okay, so they were kind of generally the most common causes that I see. Now then there are the less common causes, not to forget, sorry, the big one, adhesive capsulitis, so frozen shoulder. Now frozen shoulder is a bit of a nightmare. Why? Because with frozen shoulder, you get a very prolonged issue. Now, previous textbooks used to suggest so frozen shoulder, there are 3 stages: the freezing stage, the frozen stage, and the thawing stage. The freezing stage is where you are in pain, and you are reducing, you are progressively limiting the range of motion that you have. The frozen stage can again be painful, but here there's no further reduction in the range of motion. It's stuck. And then you've got the thawing stage, which essentially is not painful, and you are actually starting to regain your range of motion. Previous textbooks used to suggest this as being a 6-month cycle, or rather 6-month stage, all three, so in total being 18 months. More recent evidence and literature suggests this to be significantly longer. The first stage being 6 to 9 months, second stage being 9 to 15 months, and the third in a similar fashion, anywhere up to 18 months. So a significantly longer period. So it can really take time. Can manual therapy help? In some cases, yes. In others, no. I think it's very much dependent on the practitioner and the techniques that they employ. What I have found in practice usually is, most certainly I find that I can limit the progress of the condition, and I can assist with the pain, if not the range of motion. Can I prevent the progression of the actual condition and the pathophysiological processes? Not necessarily. Can I prevent the reduction in the range of motion? Quite often, yes. Can I manage the pain? More often than not, absolutely. So that's your frozen shoulder. Okay. Then we've got non-musculoskeletal causes, and I'm sure there are others as well. There may well be, but these are kind of generally the ones I see. And these are the things that are running through my mind. I'm trying to determine whether it's bone. You could have subluxation of the AC joint. You could have a fracture on the area. But again, these are less likely. You could have a Hill-Sachs lesion, a labral tear. You could have various other bits and bobs. I've not mentioned any neurological conditions here. There is something called thoracic outlet syndrome, subclavian steal syndrome, there's brachial neuritis, brachial neuralgia, or neuritis rather. And then you've got the entrapment, you've got the radial nerve entrapment, you've got the median nerve entrapment, albeit further down more commonly. And so various other causes, but the most common ones that I see are the ones I mentioned earlier. Now, non-musculoskeletal causes, very important. What we also need to consider with non-musculoskeletal causes are, the first and foremost that everybody generally knows is your cardiovascular incidents, so any incidents of a heart attack that may well give you radiating pain. Okay, I appreciate it's usually more so to the left side, but it could be bilateral and it could be up to the neck, into the jaw, plus or minus. So these are things to consider. Shoulder MI, so myocardial infarction. The other one, and usually this is the right shoulder, and they usually say tip of the right shoulder, but I wouldn't say just tip of the right shoulder on its own. Gallbladder issues. So your gallbladder, just to remind ourselves, it's just, here's where the liver is, just on the bottom part of the ribcage on the right hand side, and directly underneath it, just over here, in that subcostal groove is where the, subcostal arch is where the gallbladder resides. So it's under one of the four quadrants of the one of the four lobes of the liver, the quadrate lobe. The gallbladder, if it's inflamed, then what will happen is the inflammation will irritate the phrenic nerve. The phrenic nerve actually passes, it exits from the neck itself, C3, 4, and 5, and it travels all the way down. Now, to innervate the diaphragm, because the phrenic nerve innervates the diaphragm, the respiratory diaphragm, which again, 80% of that is inspiratory function. So if I've got inflammation of the gallbladder, it will irritate the phrenic nerve, and that will actually give me referred pain to the tip of the right shoulder. So never rule out the likes of cholecystitis or cholelithiasis, these kind of things, for the same reason. The third thing I'm going to mention here that's non-musculoskeletal is ectopic pregnancy, rupture of an ectopic pregnancy. What would happen there is you'd get an intrauterine bleed, and that would go into the peritoneal region, and given this situation, again, in a similar fashion, irritating the phrenic nerve, and the same mechanism that flows and follows. The last thing I was meant to mention, which was actually musculoskeletal but not muscular, is discs. Don't forget the intervertebral discs in the neck. Again, if you've got discitis or otherwise trauma to the neck, whiplash or anything like that, that will also give you pain, radiating pain in and around the shoulder, quite possibly. I hope that's been helpful. That's just a very quick overview, the most common things that I see, alongside some rarer incidents of shoulder pain, and what it is I'm thinking about when somebody presents to me with shoulder pain. Hope you enjoyed it, and until next time, thank you.